Good morning. Today we will be discussing about normal radiographic anatomy of maxilla. So for the ease of studying, maxillary landmarks can be divided into three regions. Like first is anterior maxilla, then landmarks in. So in the maxillary incisive region, there are so many landmarks in maxillary incisive region. And the first one we are discussing is soft tissue shadow of nose. As we all know, in order to take a maxillary anterior radiograph, we have to expose the patient from upwards, like the central ray should enter through the eye on the lip. So this is the proper positioning for taking a maxillary anterior radiograph. So while taking a radiograph like this, the nose gets superimposed over the shadow of nose gets superimposed of the maxillary central and lateral incisor roots. So in a radiograph, it appears as a uniform, slightly radio opaque band with sharp border through the middle of the roots of maxillary anterior. So this is the radiograph of a maxillary anterior too, and we can see uniform, slightly radio opaque band through the middle to apical third level of the roots of central and lateral incisors. This is denoted by the black arrow. So this is the soft tissue shadow of nose. Second one is the incisive foramen. Incisive foramen is also known as nasopalatine foramen or anterior palatine foramen. It is the oral opening of nasopalatine canal. Nasopalatine canal through which the nasopalatine nerves and vessels traverse, and it actually originates in the floor of anterior nasal fossa. So this is the opening, entry, oral terminal opening of nasopalatine canal. So this is the exact anatomical position of the nasopalatine canal in a cell. So in a radiograph, it appears as a radiolucent oval shaped area between the rows of middle and apical pulse of central incisors. So this is the radiographic appearance of nasopalatine foramen or incisive foramen. It sometimes appears as smooth and symmetric, or sometimes as a very irregular image. Can be well demarcated or ill-defined, and it can vary varies extent from the crest to the root apexes. This variability in the size and shape are mainly due to different angles of X-ray beam, which is directed for the maxillary central incisor, and variability in its anatomic size. So, the size and shape of incisive foramen varies from person to person. As we all know, bisecting angle technique is not a standardized technique, so there will be difference in the angles of X-ray which can result in changing shape and size of incisive foramen. And it can also be due to the variability in the anatomic size of incisive foramen. So in the previous picture, it is completely different from the picture that we are seeing now. The incisive foramen is more pronounced in the previous radiograph, and it is very vague in this particular radiograph. The next landmark seen in the same region is the lateral wall of nasopalatine canal. We already said nasopalatine foramen or incisive foramen is the terminal opening of nasopalatine canal. So the lateral walls of nasopalatine canal can be seen in anterior radiograph. They are seen as a pair of radio-opaque lines running vertically from the floor of nasal aperture to the incisive foramen. So you can see in the radiograph, it appears as two vertical lines starting from the apexes of central incisor or from the edges of incisive foramen to the floor of nasal cavity. They are the lateral wall of nasopalatine canal. The clinical significance of incisive foramen in nasopalatine canal, lateral walls of nasopalatine canal, is that when we are planning to put an implant in central incisor or lateral incisor region, we have to know how distant is the between the incisive foramen and the implant site, because nasopalatine nerves and vessels traverses through incisive foramen and nasopalatine canal. And also, it is a potential site of cyst formation. As we all know, nasopalatine cyst is one of the most important non-odontogenic screening anterior maxilla, and the pathognomic feature of nasopalatal deficit, it is heart-shaped cyst. So it more clearly, more pronouncedly appears in a occlusion radiograph. Next one is the superior foramen of nasopalatal canal. We already said nasopalatal foramen or incisive foramen is a terminal opening. Now there is a superior foramen of the nasopalatal canal which is seen in the floor of anterior nasal fossa. This is the anatomic location of superior foramina of nasopalatal canal. And it commonly not appear on an anterior radiograph, but when the vertical angle is steep or exaggerated vertical angle is used, it appear on a projection of a maxillary incisor. And in radiograph, it appears as a round or oval radiolucency, superimposed over the nasal aperture apical to the roots of maxillary incisor. This is the IUPA showing that black arrow denotes the position of superior foramina of nasopalatal canal. It is not usually seen in an anterior radiograph, but sometimes it appears when the vertical angle is reduced. And it is seen clearly on occlusion projection. This is the occlusion projection which shows the exact position of superior foramina of nasopalatal canal. Next one is lateral fossa or incisive fossa. It is the depression in maxilla near the apex of lateral incisor. Anatomically, it is seen as a depression or dip in between the roots of lateral incisors or central incisors. And in radiograph, it appears as a diffuse radiolucent area in the apical region between lateral and central incisors. There is a chance to misunderstand this because periapical pathologies like periapical abscess or apical periodontitis. So, we can misinterpret it as a periapical pathology. So, in order to avoid the misinterpretation, you have to check for the lamina dura in the adjacent teeth like central incisor and lateral incisor. So, if the lamina dura is intact, it is not a pathology. It is incisive fossa or lateral fossa. Next one is nasal septum. Nasal septum is a septal cartilage. Anatomically, it's a septal cartilage arising from the anterior nasal spine in the midline, which separates the nasal cavity into two. So this is the nasal septum. And in radiograph, it appears as radio-opaque shadow arising from the anterior nasal spine and upwards. So this is the nasal septum which appear in a radiographic. It is a radiographic appearance. It is seen as a radio-opaque shadow from going upwards from the anterior nasal spine. And in the lateral walls of nasal cavity, it contain a bony projection which is called as the nasal condyle. You can see two bony projections from the lateral wall of nasal condyle. And in radiograph, it appears as radio-opaque shadow extending from the lateral wall of nasal cavity, which is the nasal condyle. So these are other landmarks seen in the anterior maxilla. Next one is the nasal aperture and floor of nasal cavity. Nasal aperture is an air-filled cavity above the oral cavity. So since it is air-filled, it appears in radiograph as a radiolucent area. So in radiograph, it appears as a radiolucent area above the anterior nasal spine. You can see two radiolucent area which is separated by a radio-opaque vertical line, which is the nasal septum. So, in the nasal aperture, below the nasal aperture, we can see the floor of nasal cavity. Floor of nasal cavity is a radio-opaque line extending bilaterally away from the base of anterior nasal spine. So, from the starting of nasal septum, two symmetrical lines run bilaterally. So, to the lateral direction, which is the floor of nasal cavity. This floor of nasal cavity can be seen in anterior projection. So, anterior lamina as well anterior lamina can be seen in the canine view. In the canine view, it appears as a single horizontal radio-opaque line above the root surfaces, and it can also be seen in the maxillary posterior radiograph. So, floor of the nasal cavity is the lamina which can be seen in anterior projection, canine projection, and posterior projection. Next one is anterior nasal spine. Anterior nasal spine is a bony prominence located in the midline, 1.5 to 2 mm above the alveolar crest. So this red marked area is the anatomic location of anterior nasal spine. In a radiograph, it appears as a V-shaped radio opacity below the junction of inferior induced nasal septum and above the root of maxillary central. So, in a radiograph, anterior nasal spine seen from the starting of nasal septum above the root apexes of maxillary central incisor in midline. Next is intermaxillary suture. Intermaxillary suture starts from the crest of the alveolar bone to the posterior aspect of hard palate. So this is the anatomical location. It is an articulation of alveolar and palatal process in midline between the central incisors, extends through the anterior nasal spine, continuing posteriorly between maxillary palatal process to posterior aspect of hard palate. So in radiograph, it appears as a thin radiolucent lining midline between central incisors extending till anterior nasal spine. So this is the radiographic image of intermaxillary suture. We can see the white arrow denotes the intermaxillary suture, which starts from the crest and extends through the anterior nasal spine to nasal septum, and it extends till the posterior aspect of hard palate. Next one is soft tissue shadow of lip. As we discussed in the case of soft tissue shadow of nose, when the projection is from superiorly, and in order to get a maxillary anterior radiograph, the central ray should pass through the midline high on the lip. So it is common to appear the soft tissue shadow of lip also in the maxillary anterior radiograph. Same projection. So this is the exact positioning of patient and X-ray tube during while taking an anterior X-ray. So the soft tissue shadow of lip appears as a radio-opaque band seen at the cervical third of maxillary anterior face. It is seen in the cervical third area, and this red arrow denotes the soft tissue shadow of nose as we discussed earlier. Next one is nasolacrimal canal. Nasolacrimal canal, as we all know, it is formed by the nasal and maxillary bones. It is not commonly seen in the anterior maxillary periapical radiograph. Nasolacrimal canal runs from the medial aspect of inferior border of orbit to the inferior concha of nasal cavity. It is seen as a radiolucent area at the apex of canine. It is steep vertical angle, as we say in the case of superior foramina of nasopalatine canal. Nasolacrimal canal also seen if a steep vertical angulation or exaggerated vertical angle is used to take the radiograph. And this is the nasolacrimal canal, but it mostly appears in the intestine occlusal projections. In occlusal projections, you can see clearly the nasolacrimal canal. The black arrow denotes the exact position of nasolacrimal canal. So mainly these are the anatomical locations of maxillary anterior landmark, and we already discussed all the maxillary anterior landmarks. Next is maxillary canine region. So this is the schematic diagram of maxillary canine region. So first landmark which is seen in the maxillary canine region is canine fossa. As we said, like for the lateral fossa, this is also a depression. This is apical to canine, where lateral fossa is seen in between the central and lateral incisors. So canine fossa is the thinnest portion of the anterior wall of maxilla. And it is the radiolucent area with a fat trabecular pattern between the root of lateral incisors and canine. It can also be misinterpreted as a periapical pathology. So then we should look for the status of lamina dura. Next one is inverted Y line of Ennis. Inverted Y line of Ennis is an imaginary line which is formed by the lateral wall of nasal fossa and anterior wall of maxillary sinus. That is, it is at the intersectional line of lateral wall of nasal fossa and the anterior wall of maxillary sinus. And in radiograph, it's seen as thin radio-opaque intercrossing lines above the apexes, canine and premolar. red arrow denotes the lateral wall of nasal fossa, and blue arrow denotes the anterior wall of maxillary sinus. So at the interjunctional area, which denotes the letter Y, which is inverted letter Y. So that is why it's called inverted Y line of Amos. So from the nasal fossa and maxillary sinus, it intersects and forms the inverted Y line of Amos. And sometimes this Y line appears as X-line when there is superimposition. So if it intercrosses, it forms an X shape, which is called inverted, which is called X-line. So these are the landmarks which is in the canine region, canine fossa and inverted Y line of X. Next one is maxillary posterior region. So maxillary posterior region, there are mainly 10 landmarks in maxillary posterior region. First one is the mesolabial fold. Anatomically, how mesolabial fold appear is because when there is when muscles rest, the elevator muscles of mastication, like elevator muscles of mouth rest, there will be thick cheek tissues. So this thick cheek tissues appear on the radiograph. It superimposes a soft tissue over the bone and teeth, and this attenuates the radiation. So it is more prominently seen in older individuals. It is seen in premolar and canine projections mainly. It appears as a veil of slight radio opacity, frequently traverses in peripheral radiographs of the premolar region with sharp demarcation. So you can see the denotes by white arrow. They appear as veil of slight radio opacity, traverses over the peripheral radiograph. You can see a veil of radio opacity. Next one is maxillary sinus. As we all know, maxillary sinus is the largest paranasal sinus which occupies the entire body of maxilla, and its anterior wall is seen near the nasal fossa. We already discussed where the position of inverted Y line of Amos, and posterior wall is into the zygomatic process. Superior wall is near the floor of orbit. And the floor. The floor of maxillary sinus appear as a thin radio-opaque line distal to canine, posteriorly above the maxillary tuberosity. So floor of maxillary sinus extends from the distal side of canine to the maxillary tuberosity. See, first we discussed this is the first starting of maxillary sinus at the Y line of image, and it extends till the maxillary tuberosity. These two radiographs shows the starting and end on the terminal called the maxillary sinus. This is the maxillary sinus, the floor of maxillary sinus, which appear as a thin radiopaque wavy line. The normal variations in maxillary sinus. So from person to person or in the same person in two quadrants to arch, maxillary sinus varies. This is not mainly pathological, it can also be physiological. So they are called the normal variations in maxillary sinus. First one is pneumatization. If a patient extracts his teeth, his or her teeth, there will be a missing tooth area. That is, there is a edentulous area. So, posterior tooth extraction, edentulous area. Maxillary sinus floor extends towards the crest of alveolar ridge, which is called the pneumatization. So you can see this is the area of the teeth. In a dentulous area, the maxillary sinus appear on above the apices of the tooth, but in an edentulous area, it extends towards the crest of the alveolar ridge, which is known as pneumatization. You can see in the second picture, the floor of maxillary sinus is almost at the crest of the ridge. This is called pneumatization. This is not a pathology, this is a physiological process in an edentulous area. Second one is bony prominences in sinuses. So sometimes when we are taking radiographs, we already know the roots of maxillary molars and premolars are very near to maxillary sinus. So in a 2D image, it's not a 3D image, in a 2D image, it appears as these roots are extending into the maxillary sinuses. So this in an IOPA, which is a 2D view, it appears that it extends into the maxillary sinus. It is because of the angulation and superimposition of X-ray. So the root is not inside the maxillary sinus, it actually, you can see in an IOPA as it invades into the maxillary sinus. It is a normal variation only, not a pathological feature. Third one is the maxillary sinus septa. It is anatomically thin fold of cortical bone which projects from the floor and wall of the sinus. So in a radiograph, it appears as a thin vertical radio opaque line extending from the floor or the wall of maxillary sinus. So you can see in the radiograph, this is a vertical line which extends from the floor of maxillary sinus, that is maxillary sinus septa, which is denoted by a white arrow in the second radiograph. Third one is nodule sinus. They are radiopic, homogeneous, well-defined projections which blend with the normal trabecula. Sometimes we misinterpret this as root stems inside the maxillary sinus, but we can differentiate it from the density of pulp. In a root stem, there will be pulp chamber inside the cell. So in nodules, it is normal trabecular pattern. So this can be differentiated from the retained root by the presence of pulp canal. So you can see the white arrow denotes the nodule in the maxillary sinus. Next one is neurovascular canal. They appear as radiolucent canals within the wall of normal sinuses. You can see a canal in this radiograph which is denoted by a white arrow. It's a radiolucent band which carries superior alveolar vessels and which is in intimate contact with the membrane lining of sinus. And if there is acute inflammation of sinus, when we have sinusitis, we have pain in tooth which is known as odontogenic sinusitis. If there is any periapical or periodontal inflammation which causes the inflammation of sinus, which is known as odontogenic sinusitis. And if there is any maxillary sinus infection, we have pain in teeth, which is because of the superior alveolar vessels and nerves. So that is neurovascular canals carry superior alveolar vessels and nerves. So you can see in this picture as clearly, this is posterior superior alveolar canal, which is commonly called neurovascular canal, which is a normal variation in maxillary sinus. Next one is zygomatic process and zygoma. So we already discussed axillary antrum expand laterally through the zygomatic process of maxilla. And zygomatic process appear as a U-shaped or J-shaped radio-opaque line with its opening superiorly above the apex molar. You can see a U or J-shaped radio-opaque band in the radiograph. It is denoted by a white arrow in the first one, and second one it is denoted by a black arrow. So zygoma is the inferior border of zygomatic process which extends posteriorly, and in the radiograph it is seen as a uniform radio opacity which extends from the inferior border of zygomatic process to posteriorly above the apex molar. In the radiograph, the white arrow denotes the inferior border of zygomatic process and the red arrow denotes the zygoma. You can see from the inferior border of zygomatic process, there is a posterior extension, which is the zygoma. Next one is maxillary tuberosity. Maxillary tuberosity is a bony prominence which is seen distal to the third molar. It is a radio-opaque mass. Seen distal to third molar in the radiograph, it appears as a radio-opaque mass which is seen distal to third molar, which has trabecular pattern. Then pterygoid plate. So we know lateral pterygoid plate and medial pterygoid plate. So the lateral and medial pterygoid muscles are attached, and these plates lie immediately posterior to the maxillary tuberosity. So this is the exact, this pink arrow is the exact location of pterygoid plate. It appears as a simple radio-opaque homogeneous shadow without any evidence of trabeculation. So posterior to maxillary tuberosity, you can see it's denoted by white arrow. You can see with no trabeculation, a single radio-opaque homogeneous mass. Then hamular process. Hamular process is clinically a hook-like bony structure, which is the posterior extension of pterygoid plate. So this is the anatomical location of hamular process. It It appears as a hook-like homogeneous radiopacity with normal trabeculation. So pterygoid plates have no trabeculation, but hamular process has normal trabeculation of both. So in the radiograph, the pink arrow denotes pterygoid plate and black arrow denotes the hamular process. Next one is cornoid process. Cornoid process is anatomically seen in mandible, but it is appear in maxillary posterior projection of radiograph due to the downward and forward movement of mandible when the mouth is open. So while taking a maxillary posterior radiograph, we have to open the mouth, and while opening the mouth, mandible moves downward and forward. Then cornoid process appear on the maxillary radiograph. This red marked area is the anatomical location of cornoid process, and in a radiograph it appears as a triangular shaped radio opacity with its apex directed superiorly and anteriorly superimposed on the region of third molar. So in this you can see it is denoted by a red arrow. So these are the anatomical landmarks